Okay, here we go. Chapter 16, Airway Review. I'm going to try something a little different here. In class, we'll do what I call whiteboard drills. Lacey does them as well. That's the way, kind of the format I want you to think of these in. I'm going to pull up a slide, read it out loud, and then what you're going to do is, hopefully, is you're going to pause a video, and then get out a piece of paper and write down your answer to it. Don't just try to think about it, because then whenever we talk about it, you'll go, oh yeah, that's kind of what I meant. Go ahead and write it all out, and then let's take a look at it. So these are pretty vague, but it'll get us in the right direction. So let's take a look. Remember, after every slide, we'll pause it, and then we'll come back and talk about it for a second. So our first one, what is the first priority in assessing and managing an airway? So go ahead and pause now, write out all your answers. Okay, so first priority, we want to ensure the airway is open and free of obstruction to provide effective ventilation and oxygenation. So that's going to be our first priority in assessing and managing an airway. Now you can see at the top we got the words general airway management. So that's just telling us kind of what we're going to be talking about. So let's talk about listing the indications for advanced airway placement. Pause now. Okay, so the inability to maintain an open airway, the failure to protect the airway, so we're talking about altered mental status, obviously full arrest, things like that, inadequate ventilation or oxygenation, and then the predicted clinical course requiring airway control. So when we say that predicted clinical course requiring airway control, we're talking about like burns, trauma, those kind of things. Next slide. What is the primary purpose of pre-oxygenation before intubation? Pause now. To maximize oxygen reserves and delay the onset of hypoxia during the apneic period of intubation. Remember, we talked about patients deoxygenating and us denitrogenating them and all of that just to protect us during that apneic period of intubation. So really just prolonging that period before we get into the apneic period. Name two conditions that contraindicate nasotracheal intubation. Suspected basilar skull fracture and significant mid-face trauma. Now I do want to mention, these are not actual test questions, so if you get through all of this, you may go, hey, I'm all good, and maybe you are, maybe you aren't. These are not test questions, but I'm quite certain nearly every single question that you'll see on your airway test or a final will somehow be encompassed within this at some degree. So what are the signs of a failed airway attempt? Pause. The inability to maintain O2 saturation, the inability to secure the airway after multiple attempts, that's a sign of a failed airway attempt, and then evidence of esophageal intubation. So if you gutted them, that is as well. Now let's move on. Techniques and devices. What is the most common complications of nasotracheal intubation and how can it be minimized? Pause. Bleeding from nasal trauma. So it's minimized by using a smaller tube and adequate lubrication. And in the event that you have like the neosynephrine or can't think of the generic name for it now, but just the little Afrin type stuff that shuts things down, that has some epinephrine basically in it, then that will help with some vasoconstriction as well. But what we're saying is we want to minimize it by using a smaller tube and adequate lubrication. So describe the proper head position for face-to-face intubation. The head is manually stabilized by a second provider, not in the sniffing position. Remember, we're talking face-to-face intubation, and then the laryngoscope is held in the right hand with the blade facing downward. In these situations, we're probably going to be thinking about trauma and those kinds of things. What is the difference between a King LTD and a King LTSD? Go ahead and pause now. So the LTSD has a gastric access port for decompression, while the LTD does not. What does the iGel supraglottic airway rely on for its seal? Pause. A non-inflatable anatomical seal that conforms to the patient's airway. Now, what are the steps for confirming ET tube placement? Pause. Visualization of the tube passing through the vocal cords, end tidal CO2 detection, and then, of course, bilateral chest rise, as well as auscultation of breath sounds. Obviously, our best bets, well, our first thing would be seeing it pass through the vocal cords, and then end tidal is going to be really important as well. So what are the two main classes of drugs used for sedation during intubation? Now, if you're having trouble maybe deciphering what questions are asking, pay attention. This asks for sedation, so we're probably going to talk about some sedatives or something just for sedation, not paralytics. Go ahead and pause. So sedative hypnotics, so you might think of midazolam or etomidate, and then dissociative agents as well, so ketamine. What is a paralytic agent used in conjunction with sedatives for RSI, rapid sequence intubation? Or I'm sorry, not what, why? You picked it up right, you guys got it right. Why is a paralytic agent used in conjunction with sedatives for RSI? One pause. To eliminate muscle movement and facilitate easier visualization of the airway during intubation. So that's going to be the reason that we're using those paralytics. Still talking about DAI. What's the role of succinylcholine in intubation, and what are its contraindications? Pause. So the role is a depolarizing neuromuscular blocker for rapid paralysis. Contraindications would be hyperkalemia, burns, crush injuries, neuromuscular diseases, malignant hyperthermia. Those are all contraindications. Still at DAI, so name a common non-depolarizing neuromuscular blocking agent and its typical duration of action. We're going to talk, just remember, it says a common one. So go ahead and pause. Rocuronium. So onset around 2 minutes, duration 30 to 60 minutes. A little greater than 2 minutes, but duration is 30 to 60 minutes. What is the importance of using ketamine in hemodynamically unstable patients? Pause. Okay, so the key here is the hemodynamically unstable, because ketamine has a sympathomimetic effect, supporting blood pressure and cardiac output. That's going to be a really good option that we might use. Now, complications and troubleshooting. What are the two most reliable methods for confirming ET tube placement in the trachea? Pause. Continuous waveform capnography and direct visualization of the tube passing through the vocal cords. Going to be good ET tube placement. So what is the sniffing position and why is it used in airway management? What's the sniffing position? Let's pause now. So that's a head position that aligns the oropharyngeal and laryngeal axes. Remember, we have all those three axes to optimize visualization during intubation. What should you do if subcutaneous emphysema develops after a cricothyrotomy? Pause. So if we do see that subcu error, then we should probably suspect an incorrect placement or even that false passage that we've talked about. So reassess, correct the tube position immediately. How does a Mallampati score help predict a difficult airway? Pause. It estimates the ease of intubation based on visibility of oral structures. The higher scores indicate a greater difficulty. And then what is the management strategy for accidental extubation during transport? We want to immediately provide BVM, so bag mask ventilations, and reattempt intubation while monitoring oxygenation. Surgical airways. When is a surgical cricothyrotomy indicated? Pause. When a patent airway cannot be secured through other means due to obstruction or even trauma. So list the steps for performing an open cric. And this is just broad steps. So just, I'm going to tell you about 4. So just write down those steps for performing an open cricothyrotomy. Identify and cleanse the cricothyroid membrane. Make a vertical incision through the membrane. Insert an ET or a tracheostomy tube. Inflate the cuff. And then confirm placement and secure the tube. So what is the preferred size of the ET tube for use in the surgical cricothyrotomy? Pause now. So a 6.0 millimeter cuffed ET tube. That's going to be our preferred size. Now, what are the key complications of a needle cric? Pause. Barotrauma is one, subcutaneous emphysema, inadequate ventilation due to that small catheter size. Now, supraglottic airway devices. So what are the indications for that? Inability to intubate or to ventilate, and the need for a rescue airway in a failed intubation. Name 3 potential complications of using an LMA. Go ahead and pause now. Aspiration, airway obstruction, and then gastric insufflation. So getting all that gastric distension in there. Now, what is the purpose of the gastric access port on an iGel airway? It allows insertion of a gastric tube to decompress the stomach and reduce aspiration risk. That's the purpose of that port. And then why is it critical to avoid hyperventilation during intubation? We're talking about just a few little special scenarios here. Why is it critical to avoid hyperventilation during intubation? Pausing now. So hyperventilation reduces CO2 levels, causing cerebral vasoconstriction and reducing oxygen delivery to the brain. Now this question is talking about during intubation. However, that's why it's critical to just avoid hyperventilation unless you're required to do so. We'll talk more about that in neuro, but it's not something that you should be doing often. And it's mainly because it reduces that CO2 level so much that causes, and in turn causes that cerebral vasoconstriction. And obviously that's not going to be a good thing. So what's the role of capnography during advanced airway management? It confirms and continuously monitors proper ET tube placement and adequacy of ventilations. And this is going to be our last one. So how would you manage a patient with a suspected cervical spine injury during intubation? Well, obviously, when we talked about traumatic intubations, we would want to have a second part. We don't want to have 2 sets of hands on them, but we want to use manual inline stabilization, whether that's us or a second paramedic, and avoid neck manipulation during the procedure. So that's all I got. Just a quick little, 14 minutes. May or may not be helpful, and we'll see how it goes. If we don't find it helpful, then we probably won't keep doing them. Otherwise, we'll see you guys soon.